Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Thank you for joining me today. I'm Jean Pete, and I'm here with a repeat guest that we all love, Brandi Hackett. Brandi, thanks for joining me again today.
Thank you so much.
So why don't we start, for those of you who haven't heard Brandi before, she is a certified professional geriatric care manager, and she's a master's level medical social worker, and she specializes in the senior population. So we're going to talk about how Brandi can bring her services to help you all live a better life for the rest of your lives. I'm going to leave that vague, and I'm going to hand it over to you, Brandi. Why don't we start with who are you and how did you get here?
Okay. Like she said, I've done geriatrics now for about 10 years with my master's. I've been primarily medical, so I have stayed within the realm of nursing home oncology. I've worked with a variety of types of clients. Right now, I'm part of a team called Senior Care Options. I'm one of 7. We have 2 registered nurses. I am one of 3 social workers. We have an LPC as well as Lisa Meeks, who is the owner. We have
LPC, licensed professional counselor.
There you go. Thank you. Master's level counselor. Yes, ma'am. It's a great team, but we bring a different clinical slant. The difference in what we do is we're privately hired by families. So unlike being part of larger medical systems, families bring us in often during periods of transition. The thing that we're trying to promote now is we bring really 3 things, and those are candor. So we're bringing honesty when other people might not. True competence in a sense that we have worked this for a very long time. I think I have the least amount of experience on our team, and I've got 10 years. And then we mix all of that with pure and total compassion, which families aren't getting a lot of. So we provide that education. We're able to walk in and really do a real analysis of what the needs are. And then we're able to walk them through and provide guidance, consistent review, and we're able to be an advocate for them through this entire system that can be very, very difficult.
I love it. Candor, competence, and compassion. Did I get that right?
Yes, ma'am.
We just did a show and we were talking about being real and not being a perceived self, because real brings happiness. If you're living your true self, you are a much happier self in any way, health,
Definitely.
finance, marriage, anything. So I love your 3 words: candor, competence, and compassion. So your product or service, geriatric care manager, you mentioned it. Families hire you in addition to all the other health professionals they're seeking to help manage their whole picture care, correct?
Yes.
And the benefits of that is that they use your competence and expertise to really build all the pieces of the puzzle together, which may end up saving them, and oftentimes would end up saving them money in the long run and pay for your services in and of itself, correct?
Typically about tenfold, yes. It's a lot of people will come in even if they feel very confident in what that they might know about their parent, et cetera. What we find is most people don't know what they don't know. And unless they're doing this really all day, every day, it's a very foreign land that people are walking into. And it's very confusing. As you've already seen, there's a lot of letters used. There's a lot of acronyms. There's a lot of confusion. Sometimes people are getting information from their loved one that's trying to remain independent, and sometimes it's not incredibly clear. And then you sprinkle in anything like the delirium that we'll talk about today, dementia, psychotic issues, past family history, family dynamics problems. And what we find is a lot of the people in the generation that we're currently serving in their 70s and 80s and 90s are, let's say, hard-headed. They're very stern about keeping things private. And so sometimes that leads to families being much less aware than they think they are when they are entering into new caregiving situations. So.
And keeping things private and not talking about things, especially in that generation, is detrimental and costly.
Very.
And so this whole open, candid conversation to get to the bottom of what is best for you and your loved ones is starting you on the path and journey to a better life.
Definitely.
Hence our show's name, Better Living. So thank you, Brandi, for coming and joining us today. It's always a pleasure to have you, and you always come with very good information. And I will tell you, for her to say that she's the least competent and experienced person on her team blows my mind, because she's one of the most competent people I know in her field. So I can't say enough about Brandi, and there's no objectivity there at all.
Thank you.
Again, Brandi works for Senior Care Options, and before I forget, I want to make sure to give your contact information so that folks know how to get in touch with you as they hear you speak and realize your worth. You can contact Brandi on the phone by calling 770-579-9177, or you can email at info@seniorcareopt, that's seniorcareopt.com. And you can go to their website, which is www.seniorcareopt.com. So we've talked about who you are, how you got there, what your services are. Mm-hmm. Who do you provide these services to? You mentioned mostly 70s, 80s, 90s, but what does your typical client look like?
Our typical client would be, particularly we work with a lot of people over the age of 60. We also help a lot of disabled adults. I think our youngest client has been actually 18, but we tend, I would say, 40s, 50s, 60s with potential disability, but then beyond that, often with age and just going into the field.
Or you're working with the 40s, 50s, 60s something regarding their loved one,
yes,
who might be
very much
70,
so.
80, 90.
So we provide a lot of what we call care to the caregiver. It's and often it's the caregiver that's hiring us, because again, we're dealing with the generation right now that they don't want help. They don't know they need help. They've done it their whole life. I mean, these are the Depression era of people, and they've survived amazing things. They've been through and seen segregation, issues with education, poverty, drug issues, and they've just seen and done a lot. And often they've, worked with their own hands, and they've held jobs for 50 years. They're very strong people, and sometimes they're not wanting to share, not wanting to burden their family with information. But as you know, a lot of dealing with what we deal with, you have to get very proactive, and you need to know things before you need them. And so fortunately, in certain situations, caregivers hire us before things happen. In other cases, we're brought in a true crisis. So when everything is on fire, everything. And it's really the worst time.
Yeah, I just did a show recently on finances, and we were talking about this exact issue. You try to hold it close to your chest and be a survivor and make do and get there and just keep on keeping on, when really it would have been better if you just communicated with your financial institution and got on a plan so that you didn't go under and lose everything you worked hard for. Mm-hmm. And in the end, because you're not communicating and you're not building those relationships and making a plan, you lose a lot. Just like what you're saying. We're talking about your parents, your loved one, your spouse, whoever, but it's a whole life built. And now we're aging and our health is deteriorating. There's a very logical reason to put a plan in place. Mm-hmm. And with finances, we hire financial planners. Yeah. And with legal issues, we hire elder care attorneys. Mm-hmm. It is very sensible and logical to me, especially with the state of our health care in our nation, which is a whole nother show, that we put the money into hiring competent and compassionate geriatric case managers who can build a relationship with us and get to know all of our needs to help us build the path so that we can survive on the future journey. Definitely. So I'm just so glad to have you here today. So we talked about who your clients are. Let's talk about some signs and symptoms on when someone it might behoove them to give you a call and not wait for that crisis time to happen.
I'd say primarily when people are triggered to call us would be a period of transition. And I know that's a buzzword right now, and you've probably heard it a million times, but it's when there is a new diagnosis. We got a case the other day of a gentleman that was recently diagnosed with Parkinson's. We're seeing a lot right now of Lewy body dementia and other types of dementia. And again, these are people that had a different future ahead of them. They had bought the RV, they were ready to travel the world, and then all of a sudden they are bound to now a diagnosis that will most likely end their life. And what life they have might be at a less able point than they first thought. And so families are running into this, clients themselves are running into this. And so I think that that's a huge place where we're brought in. Again, crisis, we get a lot of hospital bed calls. So people calling us, mom's hip is already fractured. She's already in a delirium, like we'll talk about. Things are just literally, when I say on fire, I mean on fire. And in all the sectors that we work within, so the financial, the legal, so we're dealing with insurance issues. We're dealing with maybe a child that's running with the bank account. We've got just situations just going everywhere.
Or children or grandchildren that you're raising, and now you're in a hospital bed and there is no plan for them.
Oh, not at all. And so one of the questions we frequently ask and what people don't think about is, what if something happened to you? And so you are the caregiver for mom, but what if something happened to you? And a lot of people are just, they don't have an answer. They just don't. And so frequently periods of transition or crisis are huge. We also do a lot of care for families that are out of state. So let's say the family member is in Texas, but mom's heels are dug in and she is staying right here in Atlanta. And so people cannot have the proper amount of supervision to their medical care. And again, we're faced with, if things are sprinkled in, such as dementia, even if they're well hidden, it can cause a lot of gaps within things. So to be able to have someone to give more oversight, to give that analysis of what's really there. And what we're finding is people, unfortunately, are piecemealing together their care. So they'll talk to someone from hospice and talk to someone from home care and talk to someone from home health and talk to an attorney and talk to this and a that and a this. And there's not really a hub.
And there's no communication going on between those
and
folks.
No communication. And then we toss into that a cardiologist, a urologist, a neurologist, a primary care doctor, and again,
someone who actually knows mom.
Yeah. So, and it's unbelievable how messy it can get. And so it's been really, really nice for this last year to learn this discipline. And we are part of a national organization. So if anybody is listening that is not local to Atlanta that says, hey, that sounds great, but I'm in Utah. Or the care that I'm needing is in New York. The national organization is actually called the National Association of Professional Geriatric Care Managers, which is at caremanager.org. It is the certification process for us. They do all of the scrubbing down, as I say, where they look at our education, our experience, our supervision. They make sure that we're following a code of ethics. They make sure that we're actually competent to give this type of guidance and information to families. And so that's a great searchable tool for families to have sort of across the nation. But to find that hub, to find that one point person where if there is a clinical question or there is my mom hasn't answered the phone for 3 days, can someone go over to check on her type of thing, where we can help to do that as well as manage everything else that's being brought into the home.
I didn't think about that, hiring you as the caregiver for a parent or a loved one who's in a different state. How much peace of mind that gives me as the daughter of a parent who lives out of state, and what all that means, because that means I can pick up the phone and call one person who has the full snapshot of all the pieces of the puzzle for my loved one. That's an added benefit. It didn't even cross my mind. What an important service. And in this day and age, you have relatives that just aren't going to pick up and move and live with you because they've fallen ill. This is their life. And we take so much of their life away from them if we move them.
Yes.
There's no right answer. But if they have to be far away, I don't see anything better than getting a geriatric care manager. Because you're pulling in financial, legal, psychosocial, health, all in one piece. And you're keeping that together. You're the general contractor.
We are.
If something goes wrong with the house, they don't have to figure out with the plumber, the drywall guy. They're just calling the guy in charge and holding them accountable.
Yes.
I love it.
Definitely.
Okay, so let's talk about some of your scenarios. And you keep mentioning delirium. So why don't we go there? Because that does happen as we age. Alzheimer's is getting more and more prevalent, and this is one of the symptoms.
It can be. To start, I want to tell a little story about how I got introduced to delirium. And it was when I actually worked in the nursing home, and I'm going to change the name in order to protect privacy, but let's call her Miss Sally. Miss Sally was by far one of my favorites. And we have those, sorry everyone listening, but people that work in facilities tend to have those that they just connect with. And Miss Sally was one of those people to me. And she had a little tad bit of confusion here and there, but every single day she was able to do most things for herself, and she would wheel herself into her doorway, and that's where she would watch, everyone as they were going by. And she did not miss a day where she had on her lipstick, her earrings, her hair done. She was beautiful, absolutely beautiful, both inside and out. And doing well overall. Like I said, generally okay. One day I was sitting at my desk and I was doing some documentation, and something sort of crossed my visual field. And I looked up, and it was literally Miss Sally. She was in nothing but a brief. Her hair was an absolute mess. She had on no earrings and no makeup, and she was walking herself down the hallway, basically naked. My initial instinct was to run for a blanket, and so I basically ran for the closest thing to covered her up, and just thought to myself, what in the absolute world has happened to my honey? And so I remember that was my very first introduction to what this is. And what I learned from that was what had happened is she had actually developed a urinary tract infection. She was able to toilet herself, and so the staff allowed her to do that, to remain independent. She had gotten an infection that had developed so bad that she was actually bleeding. She was hiding all evidence that this was occurring, so the staff was not aware. And I definitely want to stress this was not a competence issue with the staff at all. She was truly independent with this need. And she was hiding. No one knew until it had gotten to a point where she actually had developed a blood infection as a result of the urinary tract infection. And unfortunately, in her case, the underlying dementia that was starting to bloom and blossom progressed. Again, this was separate from her dementia. This was not a dementia progression, which is scary, and we'll talk about the difference and what that means. But for her, it was an acute issue that came out of nowhere that, left untreated, made her virtually psychotic. And I think back, this was 6, 7, 8 years ago. And I think back of what that felt like to me. What if she were conscious that she was walking down the hallway naked, that this poor lady, and I just remember thinking, whatever this is, we need to know what this is, and we need to know how to treat it so that people aren't dealing with this. And so, when we talked about topics to bring on and topics that I think need to be discussed, I think that delirium is huge. Delirium can have very, very similar symptoms to dementia. So can be difficult if people already have a diagnosis or already have memory issues to start seeing this. Delirium can show up in a lot of different ways, and we'll talk about that. But basically, delirium, just like the word dementia is a set of symptoms, delirium is also a set of symptoms. And what it basically is, it's a set of symptoms, and we'll talk about what you're going to see, but it's resulting from usually an underlying disease, medication. It's a new issue or a combination of a varied amount of things that will interrupt the normal processing in the brain. And so what it does is it leaves the brain unable to work and function normally. And so it's sort of misfiring, malfunctioning. And the difference between a dementia and delirium, one of the major ones, is a delirium comes on suddenly.
Out of the blue. So
you're going to get progression within hours, days, weeks, as opposed to a lot of the progression that we're seeing with an actual dementia. So where it's going to be rapid, it's going to be severe. One of the difficult things with delirium is it's varied throughout the course of the day. So there could actually be periods in the day where there are no symptoms. So it can look almost like a fluke. It is actually, delirium is one of the most common disorders that we're seeing within the hospital. And it's often something that is sending lots and lots of people to the hospital. And I know we're looking at ways to try to keep people from being readmitted. Delirium is something that definitely occur. I think the statistics that I read were about 10 to 20% of all adults, 40 to 50% of all seniors. And for those that are actually in the ICU, they're looking at about 80% prevalence of delirium. And so it's important to know what this is, and that's what we'll talk about a little bit more today. But what they're finding is it leads to longer hospitalization. It leads to a higher functional decline. It's going to lead to often increased use of physical or chemical restraints. We're seeing higher rates of nursing home placement, typically about threefold for people that are experiencing delirium. And there is some recent studies saying that it's linking to a higher rate of mortality. So that people that are experiencing these set of symptoms are often at a higher risk of dying. And the studies that I've read recently have been within the 12 months following the delirium.
It's scary to me when you're talking about 50% of seniors, 40 to 50% of seniors, and then you put these caregivers who are caring for their loved ones with dementia, and how scary this can be to a spouse who is of the same age and having to deal with that. And what do we do? How do we treat it? How do we keep them from going to the hospital and settle things down and give them tips to recognize what it is or what it might be? I mean, if it's a UTI, we can get somebody on antibiotics and help them get through that, correct?
Definitely.
So they don't always have to end up in the hospital. And in this day and age, people can't afford the hospital bills.
Not at all. Not at all. And I think what's most important is knowing that baseline for the person, because if we're going into a certain situation and you're not aware of the baseline of, what is their normal. And so you have someone that maybe has memory issues, but because of this, again, variation of symptoms, the fact that it's severe, but a lot of people just say, oh, their dementia's getting worse.
Yeah, and then you get to the point as the caregiver, I don't think I can handle this, but it's a delirium issue, not a dementia issue. And if we educate and inform and help identify what it might be so they can get the proper treatments, they can probably stay on their path of keeping their loved one at home with them. And again, this is why it's so important to have someone like you in the picture advocating for the loved one, getting to know the family and the loved one and their needs, and you can be that call and you can help manage that care. And maybe it is that you say they need to go to the hospital, or maybe it is that you say, I'm going to send somebody over. Let's look, I'm going to come with an expert in blah, blah, blah. We can do a test. I think it might be a UTI. You have nurses and social workers. Is that how you work with families?
Definitely. And I think, if we know things that are already underlying, if there's developmental disabilities, if there are dementias, psychiatric disorders, depressions, we're also seeing a lot of learning disorders that are showing some complexities when it comes to identifying symptoms. But it's extremely important to know that delirium can be outside of all of these diagnoses. And unfortunately, because it can look the same, and we'll talk about what that actually looks like in a minute, but because it can look the same, it's often looped in. And so people will not treat it, or they'll overlook it because they think that it's a portion of what the person's already dealing with, when if it is truly treated, then there is quite a reversible way to manage the symptoms.
So again, I just want to shout out a way that you can get in touch with Brandi, no matter where you live, because she can connect you through her association, which is a national association, to the right person in your area. Brandi is here in Atlanta, and her contact information is 770-579-9177. She's going to be candid. She's very competent, and I know her to be compassionate. You can also email her at info@seniorcareopt.com or go to their website at www.seniorcareopt.com. We have to take a quick break, but we will be back to talk more about delirium and how geriatric care management can help you and your loved ones. Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Hi, thanks for staying with us today. I'm Jean Pete, and I'm still here with Brandi Hackett. Just to remind you, Brandi Hackett is a licensed master of social work, and she's also a certified professional geriatric care manager. And she's with us today talking about geriatric care management and the importance of having a geriatric care manager in your life. Before the break, we talked a lot about what she can do for you as a loved one or you as a patient in helping you get your big picture together regarding your health, your legal, your financial situation so that you can live your best life until the end of your life. But prior to the break, we started talking about delirium, and I think there's a lot of important information that we need to get out to you because there's an awful lot of folks at home caring for a loved one with some form of dementia, whether it's Alzheimer's or Lewy bodies or whatever form that is. And there's also a diagnosis, a disease, I don't know what you call it, a symptom. Actually, that's a good run-in for you. Let's talk about the definition of delirium, Brandi. What you all don't know is I can be a little delirious on this radio show, and Brandi's a repeat guest. And so Brandi not only took my questionnaire, but she gave me an outline so that she could keep me in organized fashion and not delirious on this show today. So she's kind of laughing at me because I'm going to her structured outline. So Brandi, what is the definition of delirium? Not to call you out, but to call you out.
No problem. I've known you long enough to know that it's not personal. Delirium, like we mentioned before the break, is actually a set of symptoms. And the most important piece about delirium is that it occurs over a very, very short period of time. So you're looking at few hours, few weeks. It's super fast that it's coming on. The core features of this symptom is going to look a lot like a lot of the illnesses that people are dealing with already. So I wanted to go briefly over what the symptom actually looks like. What they see, probably the main symptom and a huge difference between this and dementia is the person actually has a greatly reduced ability to focus, sustain, or shift their attention. That is one of the huge red flags. So if you have a person, even if they are diagnosed with another thing that they're dealing with that can affect their concentration, that if they have a large shift in their ability, that is a huge red flag. Also, they can show reduced awareness of the environment and have difficulties connecting to things, people, etc. in their environment. Often you will see that there is a change in their cognition, their memory, problem solving, judgment, they're disoriented. Sometimes there's memory impairment. However, this is not always the case.
So it's scary, though, because everything that you're saying sounds like dementia.
Yes.
So
yes.
How do you know this is not the normal path we're on with my loved one with dementia and me caring for him? Mm-hmm. There's something different. How do you not? I can see how this could go undiagnosed and untreated because it sounds so similar.
Very much so. Well, and I think the difference is knowing your baseline. Having a real awareness of what that person's skills, abilities, cognitive levels are. And it can be typically a severe or sudden change, but some of the changes, as things are developing, can be a little harder to identify. And so it's often nice to have in place, whether you go through a neurologist, et cetera, to have some of the nationally used screening tools for dementia in place so that you know what the baseline is for your person. So if they have a shift to that. But again, it's, we'll continue to go through this, but it's changes within these symptoms that are incredibly different from how they normally are and how they're normally presenting. So again, that change in cognition is going to look very similar, but you're looking at an instant or a sudden shift or change. And again, go back to that attention.
Not just a gradual change. It's a sudden,
yes,
out of control, out of the norm, significantly change.
Major, yes.
And it may not last, like you said.
And it might, which again can be a little confusing, but it might be better or worse at different times of the day. Typically with a dementia, you'll see that people will generally have a certain level of ability. And even though it might spike like a sundowning, like a lot of people are familiar with, towards the end of the day, there might be a spike in behavior or symptoms. It's generally the same level. And that level will progress typically with dementia as people age into their illness. And dementia is typically about an 8 to 10 year prognosis. And so this, again, very differently, can happen to people with no dementia. People with cognitive issues actually are at a higher risk for delirium. However, it's not necessary. And people, like I said, often if people are having a delirium brought on by pain, they might not be confused at all. They might be in their 40s.
Let's talk about those, what causes delirium, the causes. If it's not dementia, what are the other instances? So you don't freak out. If someone has something going on in front of you, you can say, hey, wait a minute, I heard that radio show. I think this is what this might be. What are some of the causes?
What we're seeing is that there's it's a combination of things. So people, if they're in a higher risk category and they have A, B, C, and D. So the higher risk category would be...
there she is getting me back on her outline. That's so funny. I missed the question. Who is at a higher risk?
Older adults, people with cognitive issues, people with a risk of infection. So people that might have an indwelling catheter, people that have multiple physical or psychiatric issues.
I like the idea. I just want to bring you back to infection because it can be a bite. Right? From some kind of a bug, and it's gotten infected. And so it could be someone younger, and all of a sudden they start acting crazy, and you don't know what the heck is going on. This is what it could be. They have some kind of infection in their body, which is very treatable. And if this show does nothing but keep you calm and think about, well, maybe did they get bit? Did they have a wound that might be infected?
Typically with infections, we see that those of greater age are most affected by infections, but the infections that we want to sort of call attention to would be urinary tract infections is a huge one. Pneumonia is also big. Sepsis, which is what my sweet lady developed from a urinary tract infection. Also, some skin-related infections can transition into a point where there is a larger issue.
And here's where it comes into play with people who do have dementia, because you could write it off that this is just an episode of the dementia, when in fact they have an infection and your loved one could end up septic. And
Definitely.
that could take their life. And this is why it's so important to recognize that if something peaks way out of control, you need to you need to get someone, your loved one, somewhere to get tested, because you could prevent them from being septic.
Oh, 100%.
And that is I know several people. I almost lost my brother-in-law to that. And he was in his mid-40s at the time. And he got an infection and he was septic and he was acting crazy. And this is probably exactly what this was.
It definitely could have been. And with
I think he had his appendix out. And I think he got an infection.
It can definitely happen. And I think, again, it's what we tend to see is it's not one thing. So you have someone that has a UTI, but they also have a cardiac condition, and they also have an underlying dementia, and they also have, and we're also seeing a lot of people that have closeted issues with alcohol or drugs. That's coming into play, often combined with visual impairments or sensory impairments, because again, this is how we connect with the world. So if the person, one of the major symptoms is having that reduced awareness of their environment, and you throw in something like cataracts, plus A, B, C, and D, and E. And then also, again, we'll talk a little bit more, but issues with hospitalization or being in a facility type setting can sometimes put people more in what we call the twilight zone. So they're just a little disoriented to begin with. And often if your days all look the same, sometimes it's hard to keep up with things. And so what we find is that's sort of the risk category. And then you tack onto that issues like, and I think the major ones would be, again, the infection. Another one that we see a ton of, the record that I have seen working with a client family is 39 medications for one client. But polypharmacy, which is what that's called, or medications are poorly maintained, especially there's a couple that I want to highlight. Anticholinergic medications, which are going to include antihistamines, antipsychotics, muscle relaxers, medicines for Parkinson's, and medicines for urinary incontinence, as well as pain medications and sleeping pills, which, if you can think of anybody, often seniors are on a ton of those and a mix of those. Also, pain and psychological stress can bring on the shift. And then what we see, again, it's very typically a combination of a true medical issue mixed with medication toxicity, mixed with higher risk factors, and then we toss in things like alcoholism, et cetera. So it's often incredibly complex. And so when we talk about, the symptoms, it's important, how in the world do you test for something that looks this vague and that could be anything else?
And I do just want to take what you just said, because this is, again, a reason why you really should look into a geriatric care manager. I know healthcare costs are exorbitant. Our country is one of the most expensive and least effective healthcare systems in the country, in the world. However, statistics show. However, 39 medications. If you have a geriatric care manager, they're looking at the big picture. Mm-hmm. They're helping you or your loved one manage their own care. And you might have one doctor with one specialty, a primary care physician, plus you're doing the over-counter thing. You don't know how they mix together. That is so important and can prevent these delirium episodes. Mm-hmm. So important. And right there, one hospitalization prevented is a lot of money in your pocket, and it pays for itself.
Mm-hmm. Definitely.
So I just wanted to stop you, because 39 meds, and we see it all the time. Mm-hmm. I've worked in healthcare for years. We see it all the time.
Just last week it was 22 with another client, and it's and people say, well, how in the world does that happen? How do you get 22 meds? And what we find is people have so many physicians involved, and again, those physicians are not talking. And so they'll go to a cardiologist and get 4 meds from them, and their neurologist, they'll get 7 meds from them. And then, and before you know it,
the pharmacist at the drugstore on the corner, and they get a cold, and
it's unbelievable. And again, what we find a lot of times is they're not benefiting from the medication. That's a huge one. There was actually just a lot of research put out on Alzheimer's meds and people taking them beyond their benefit. And so
it makes me think, I don't mean to cut you off, but I like to give people visuals. I have a pool, and I went away last year on vacation, and my sister thought it needed chlorine, but I didn't have chlorine tablets, so she stocked the pool, which is normally okay, except I had just gotten all the chemicals right before I left for vacation, and my pool was awful, turned green. We could not get it right. And I knew it shouldn't be green because there was so much shock and chlorine in that pool. I brought the pool guy out, and he said, you are in what's called chemical shock. There's so many chemicals. None of them are working anymore. Mm-hmm. And your pool is not going to get healthy and pretty and clean until we get rid of what you've put in there and start all over again. Mm-hmm. And that's what it reminds me of. Mm-hmm. Everything works against each other, and then everything stops working.
Mm-hmm. And so, delirium, the problem is when people are in this state, you're in a crisis. That's a crisis. So when any family starts seeing these symptoms, they go, something's got to be done. And often, again, this is a reason many people go to the ER. And so they're in the ER.
Or put mom and dad in a facility.
Oh, yeah. Oh, definitely. And so, but this might be the first time that the child realizes how many meds mom is on. And so it's, and at that point, it's all keeping it consistent. Keeping it. And so there's not a lot of times that people go in and re-explore. And so I know hospice is a time where we see a lot where, nurses come in and say this med might no longer be helpful or beneficial. And sometimes families are like, well, she's always taken vitamin D. Why wouldn't we continue?
It's hospice. You're at the end of your life.
Oh, yeah.
There's no need to wait that long to reassess what it is that you're doing.
Goodness, no. And I think that, when someone goes in with a delirium, because it has so many changes and because it's so complex and because, again, we're talking about this really broad set of symptoms that look like everything else, they're going to try to sort of slice it apart very differently. So they're going to get a family history, typically from whoever brings them there. And again, this is a situation where families don't know what they don't know. And the most important thing about treating delirium or figuring out what this is what were they before? You know, if this person came with a certain level of ability and they're a little bit off, sometimes you don't notice. But if it's, you know, you or I, and we walk in and all of a sudden we're walking down the street in our underwear, there's probably a huge problem going on. But if I don't know that that's not your normal,
you're going to get more meds.
You're just going to get more meds or restraints, et cetera. And so, you know, when we're talking to families, you know, whether they're using care management or not, you know, the things that they need to hone in on would be, what are their diagnoses? What are their general symptoms? What do they typically look like? You know, if it is something that they're coming that's acute, what are the new symptoms? Has there been any recent issues with fever, falls, head injury, etc.? Are they showing signs of paranoia or hallucinations? And what this is going to do in combination with some neuropsych assessment, mental status assessment by the hospitalist or whomever you're seeking treatment from. And then they also order a series of tests typically, and they're going to look at things like complete blood count, comprehensive metabolic panel, chest x-rays, liver functioning, big one, urinalysis. Always ask for that. That's the...
often it's a urinary tract infection.
Very often.
Very treatable.
And the culturing of that is extremely important because it's going to tell you which bacteria you're dealing with so you know which antibiotic is actually going to fight it. So they're going to do a host of things, sometimes CTs, sometimes MRIs, sometimes EEGs. And so all of a sudden they're sort of thrown into this gamut of testing. But what they're trying to find, and the purpose of all of this, is what is causing it. Because with delirium, like I said, there's always this organic cause underneath. And so if they can find the organic cause, then treatment is going to be most successful because hopefully they've caught it in a point where the symptoms that are showing are going to be more temporary and sometimes even reversible if they're actually treated correctly. So the more accurate history and baseline a family can provide, mixed with all the testing evaluations that the care provider is doing, is going to help to label what is causing this, which in turn will help to say, how do we treat this?
If you get to the cause, you treat it correctly.
Definitely.
And if you treat it correctly, you can get rid of it or keep it at bay.
Definitely.
Lessen the symptoms.
And I think one of the major things is people, again, we're always sort of just trying to throw water on the fire, but this is a brain issue. And so it's also important, if there is a major brain issue, that we're looking at sort of optimize the healing of both the body and the brain. Because sometimes we're dealing with infection, but often it is triggering major cognitive issues. And so we're looking at things like making sure they're getting proper hydration, making sure they're getting proper nutrition. They're seeing a lot of research now on making sure that their sleep is interrupted, which is a fun task in the hospital. And they're also saying that the exposure to sunlight during daylight hours can help to reset that sleep-wake cycle, which is often something that is a symptom of delirium. People are having issues with sleep. And what they're saying now is sometimes that is the first symptom that we're seeing, is that if all of a sudden they're having issues with sleep, sometimes that's a precursor to going into a delirium. So that's another trigger.
And again, that's so symptomatic of somebody with some form of dementia. So it's a tough one to... And another reason why a geriatric care manager is nice, they can give you a call and you can say, well, you know what, it might be this, and ask the right questions using your assessment tools to try to assess whether it's delirium or not and get you the help you need before it becomes the crisis. I do want to get your information out one more time because I think it's so important that we get the help to folks. If you want to get in touch with Brandi at Senior Care Options, you can contact her at 770-579-9177. She's right here in Atlanta, and it's www.seniorcareop.com if you want to go to the website. Now, if your loved one is out of state, please remember, it does not matter. She can connect you to anywhere in the country through her association for, and I don't remember the long title and the long Association for Geriatric Care Managers, 770-579-9177. So, we've talked about the benefits of having a geriatric care manager. We've talked about stories on how you've helped folks. We could get into more stories, I think. We've also talked about dementia and delirium at length, and we've discussed, according to your outline, the definition, who's at risk, what the causes are, that there are tests and screenings that can be done and how it can be treated, and sometimes the prognosis is reversal. Can it be prevented?
Often it can. And again, we're looking at some of the risk factors that are already in place. And so we're looking at things that if there is a hospitalization or a need for a hospitalization, trying to avoid things like sedatives if possible, keeping somebody restrained or immobile. Bladder catheters are sometimes can be a problem. Sometimes also helping people orient to their reality. So if you're bringing in their eyeglasses or making sure that a family member's present so they feel familiar, definitely. And then also what they're finding in general is good things that we already know are also ways to avoid delirium. And so we're looking at avoiding illness or infection in general, reducing alcohol consumption, not smoking, balanced diet, regular exercise, hydration, etc. Vaccinations to prevent pneumonia and flu are often and then also the big one, exercising caution and frequent review with medications. But they're finding that even if you were to develop it, again, focusing on the whole person as opposed to just pieces of that person. So not just throwing an antipsychotic, a Haldol at it because it's a behavior, but actually looking at the why and thinking that there could be a why, which is the major. And if the why is treated, that's the beautiful thing. If it is a delirium, very, very frequently are the symptoms better managed. And when that happens, it's just going to be a better quality of life in general for them. And sometimes, though, if things are already in place, it's not as reversible. And so what they're finding is the quicker it can be caught and treated, the higher likelihood is that it is almost completely reversible.
Like so many things. So if you are caring for a loved one who is exhibiting some of these symptoms, please go to, if you're not ready for a geriatric care manager, or at least give Brandi a call first. But seek your doctor. Tell them you heard this show and you heard something about delirium and could this be what's happening and can we treat it? Because you, like everything, the sooner you get to it, the better off you are. And it is reversible in some instances depending on the cause. And again, remember, oftentimes it is triggered by a urinary tract infection. And that's very treatable as well. You can do this. You need to get some help and reach out. Brandi, I can't thank you enough. Always, always full of very important information for our folks in the communities that we serve. It's a pleasure. I'm Jeannie Pete. Thanks for listening. Have a blessed day and week ahead. And listen here, same time next week and every week. Homestead Hope Foundation is your resource for a healthy life. God bless.